Well, thank you so much, Robin, for that, and welcome to our guests for today. Both Tom and Jack are from the Bay Area, and so that's fitting because this is technically the Los Angeles Patient and Family Seminar. So it is a virtual event and is now open across the country, but it was certainly intended to be a California activity. And so as Robin mentioned, we have session 1 and session 2. The subtext of this is that despite the COVID crisis right now, I think that what we all want to emphasize is that ongoing myeloma care is actually the top priority. And to the extent that we can continue with the exact care that is the best recommendation, we really want to do that. If that care needs to be modified in some way because of the COVID crisis, then obviously we will give some guidance on that, but the top priority is to maintain myeloma care to the best extent possible. And so with session 1, we will go through the different phases of myeloma therapy, starting with Frontline and going through to the discussion of newer therapies. And so the first aspect is frontline therapy. And the key point about frontline therapy is actually how much it has improved in recent years. And so for many patients who have obviously gone through frontline therapy some years ago, but are part of support groups, it's really, really important to be aware of what the status of frontline therapy is and what can be communicated to those new patient members who are coming into the groups and are really anxious to know what are their options and also what are the outcomes these days with the frontline therapies that we have available. And so if we look at managing myeloma, we have the initial therapy, and this is on slide number 6, just in case people are trying to track where we are. And so in the initial therapy, there's obviously a choice to consider transplant or not. I would say frequently, particularly in the US, there's an intent by patients and doctors to kind of keep the option for transplant open. And so often a therapy is considered or used which allows a choice of transplant or not during those first months. Subsequent to that, a transplant can be utilized, and we'll talk about the value of that, and then either maintenance or ongoing continued therapy. On this slide number 6, I also list what is an annual manuscript. Vincent Rajkumar from the Mayo Clinic, every year he does an update, and so he recently published his 2020 update on diagnosis, risk stratification, and management. And so this is actually quite a good reference tool where you can see what has changed from the previous year. So what is most remarkable about frontline therapy and therapy throughout the course of myeloma is how many new therapies have become available in recent years. And you can see what things used to look like, and then all the way from the frontline therapy to the relapse scenario, you can see just how many additional agents are added to the list. If you look at that list over to the right, the relapsed list, you'll see actually there is one addition at the bottom there, belantamab mafodotin, quite a challenge. This has just recently been approved, and the trade name is BenRep. And so this is the monoclonal antibody drug conjugate that we'll talk about during the session today. But just really remarkable what all the different options are. And you'll see that a number of the drugs over on the right have moved over to the maintenance and to the frontline setting. So the start of therapy is faced with a choice of what drugs to use, and right now there is a choice of triplets, And the VRD study, I had the privilege to lead this particular trial here for the Southwest Oncology Group, the 077 trial, which indicates that this trial was being developed back in 2007 and currently has right around a 10-year follow-up. And this study focused on 2 regimens for the first 6 months of therapy. And so this study reflects a number of things. One of them is how important that first 6 months of therapy is. And so in this case, there was a choice of 3 drugs, Velcade, Revlimid, and Dex, versus the 2 drugs, Revlimid and Dex. And so this study in slide number 9 was recently updated out to 10 years. If you look across the bottom, it goes out to 120 months, which is really pretty unusual for a trial to have comprehensive 10-year follow-up. And you can see that the average length of remission, the progression-free survival, is 41 months with the 3-drug combination VRD. And rather remarkably, the overall survival over on the right was 80% at 4 years and continues to be 55% at a median of 7 years out. And so actually the true median overall survival has actually still not been reached for this particular trial. So the question is, what are other options that have emerged? And so one of them has been the introduction of autologous stem cell transplant, ASCT, in addition to the VRD, and the international, the IFM, the French group, had a trial with VRD plus or minus transplant, the IFM 2009 trial. And what you can see on slide number 10 is that the PFS is in a similar range to VRD, and the overall survival early on is also actually fairly similar to just the VRD. And we're waiting to see what will be the longer-term impact of the autologous stem cell transplant in this trial. But what we had all been waiting for quite some years has been to see if replacing the Velcade with Kyprolis would lead to a better outcome in the frontline setting. And so at the ASCO meeting this year, we were very, very keen to see, well, what was the result of the Endurance trial led by Shaji Kumar, in which Kyprolis, carfilzomib, Rev, and Dex was compared to Velcade, Revlimid, and Dex. So the key thing to remember and to know about this is that this particular trial did exclude high-risk patients, those with 1420, 1416, deletion 17p, and other characteristics of high-risk disease. There was a parallel trial in SWOG that was available for high-risk patients. This trial, however, did include 1114 and 1414 and 1Q plus if it was present, but it was not studied. This is possibly the last of the what we could call old trials in the frontline setting, in that it was restricted to patients who had clinically symptomatic CRAB features. It did not utilize the new slim CRAB criteria that were introduced in 2015. So the disappointing result of this large study with over 500 patients in each arm was that the remission, the progression-free survivals were basically identical for the 2 arms and in a similar range to the SWOG study and to the IFM 2009 trial. What was different was the adverse events that the Kyprolis did contribute in the one arm to increased cardiopulmonary and renal toxicities, whereas, as we know, in the Velcade arm, there was increased Velcade-related neuropathy, leading to some discontinuation of the therapy. And so the bottom line, though, was that since KRD does not improve the remission, the PFS, and the toxicities sort of balance out, different in type, and the overall survival was the same. That really it leaves us with VRD as the continued standard of care at this point as a triplet, as a 3-drug regimen. In the patients who are in the non-transplant category, we do have another triplet to consider, though, and we were also excited to have published last year the results of the Maya trial, in which Daratumumab Revdex was compared to Revdex, and this has very, very excellent results, which are quite similar to VRD, as a matter of fact. And so we have an alternate triplet in the frontline setting, particularly in the non-transplant setting, which is where the trial was conducted. A couple of smaller points. Recently, the results of the Stamina trial were evaluated, trying to figure out whether double transplant, whether 2 auto transplants would give a little bit better outcome. Overall, in this trial, it did not. However, analyzing the treatments by treatment actually received, there was a trend towards some benefit with the double transplant. But I'll be interested to see what our panel think about that. One striking observation of this particular study was that it does make a big difference if you continue with lenalidomide with Revlimid as a maintenance or not. If you stop the lenalidomide, the relapses do start to happen, and this was quite an important observation in the longer-term follow-up of this study. And so the first area for discussion with our panel is, are we happy with a triplet like VRD, or are we really waiting for a quadruplet in which, for example, Dara would be combined, and we'll look at some of those data in just a minute. But so Dr. Mikhael, Joe, are you comfortable just with a triplet right now, or are you really anxious to be moving forward to a quadruplet?
Well, thanks, Brian. It's always a pleasure to be a part of this, of course, and to share the stage, as it were, with Jack and Tom, good friends. I'm blessed to be here with you. You know, I think we have thankfully reached an era in frontline therapy where it isn't simply one size fits all. You know, each of these studies have contributed to us further information, which is that I think right now the standard of care, whether someone's going to a transplant or not, is at least a triplet with 2 out of the 3, if you will, major classes. More often than not, VRD, and I'm not just sucking up to you because you led the VRD study as the chair, but that there are some patients in whom we may use DRD, and indeed some patients in whom we use KRD, despite the endurance study. And that I do think, however, in answer to the second half of your question, that we will likely see a greater use of quadruplets, of adding Daratumumab to that. I'm not sure absolutely every patient would get a quadruplet. I think the same principle of myeloma is a very diverse disease, and we don't just cookie cut the same for everybody. But I do think that in particular, those patients who are going towards an autologous stem cell transplant, we have seen the benefit of adding that 4th drug. So we have, if you will, 3 major classes of novel drugs so that we can get control of the disease early. I think one thing that's common to all of this that you shared so well, Brian, is that we are appreciating that early treatment of myeloma makes a difference in the long term. That, you know, 6 or so months of Velcade that you showed in your study has a continuing survival advantage several years later. So we don't want to save the best for last. As I sometimes say, that sounds great for a romantic song or movie, but we want to use their better treatments up front. And I think we'll probably go to quadruplets, but maybe not for absolutely everybody. But that principle of combining different drugs together will be, I think, important.
Right. So maybe Jack Aiello, how does a quadruplet versus a triplet sound to you from the patient perspective?
You're on mute, Jack. You're on mute.
Yeah.
I'm thinking about the patients, the elderly patients who are not transplant eligible, who are, sorry.
Oh, no.
Well, maybe go back to Jack. So, Tom, do you want to make some comments here about triplets versus? Oh, there we go.
He's back.
He's back.
Jack is
back.
How many buttons? Anyway, I'm thinking about the elderly patient who's more frail, who's not transplant eligible, and has a difficult time with necessarily more drugs as a 4-drug regimen. And actually wonder, do you think the same will happen for those patients? Will a 4-drug Dara plus triplet become the standard of care for them?
Right, and so as you're kind of implying, I mean, we need to wait and see. Is if you start with a triplet and then like save the Dara for later, will the ultimate outcome still be good? We don't know the answer to that question actually. So Tom, what's your perspective, just as a initial thought?
Yeah, so a couple things. I completely agree with what Joe and Jack said, and again, thanks for involving me in this. This is always very fun to actually be on the stage with you guys, but also to answer all the patient questions that come through, which are usually amazing.
Exactly.
In your study, Dr. Durie, you showed, that RVD actually is darn good therapy for even the transplant ineligible population. And so we do have really good therapies right now. And as a benchmark, we're looking at having an initial remission duration of about 3.5 to maybe 4 years. And the question is, can we do better without doing, more harm, given more toxicity? So we have, you might say this, but we have 2 additional studies that are coming down the pipe. We have the Perseus trial, which is a very large randomized phase 3 study of Dara RVD versus RVD, which hopefully will lead to, approval. And we have the EMROS trial, which is isatuximab RVD versus RVD in non-transplant eligible population. So those studies will be really important to see if we can push that 3.5 and 4 years of remission duration to maybe 5, 6, or some people think 7 years of remission duration. That would be amazing. But my final comment would be with KRD versus RVD, I think those data show that in the standard risk patients, both of those regimens are great regimens. There might be some biases from some of us, including myself, that KRD might be better for high risk, but that study was a great study, and it showed that those are both equal types of therapy.
Brian, can I toss in one last comment around that? I think when we started the discussion, I remember even when you were designing that wonderful SWOG study of VRD versus RD, there was the sense, well, older, more frail patients perhaps could never get a full triplet therapy. We would only have to be in doublets. And now, Jack raises a great point that are we in that same discussion? The one other subtle point here is that I jokingly say you have a regimen of VRD, but you ask 10 myeloma doctors how to give it, and you'll get 12 answers. That I do think we can adjust each of these drugs, the bortezomib, the lenalidomide, the daratumumab, the carfilzomib. Each of these drugs can be modified in a way to make it more effective and less toxic. And I think that will be some of the devil in the details that will be important, because we don't want to just blanket say, you're going to get a quadruplet and you're going to like it, and we're going to end up harming people. I think we really need to have that. And our experience with these drugs have really helped us know that we can match the regimen to a patient's comorbidities, not just age, but their comorbidities. I think that is so fundamental. And even the endurance trial taught us that. There definitely, I agree, a lot of patients who could benefit from carfilzomib frontline, but we want to select the right patients and give it in the right way.
Absolutely, absolutely. So one part of your comment was observed in the SWOG trial, which was that older patients were included, and they were the patients among the 30% of patients actually who ended up getting reduced Velcade or stopping Velcade. But what was remarkable, even if an older patient only had that Velcade for 3 or 4 months, they still had a benefit from it. And so it really gives encouragement to the idea if you give like VRD light or a modified regimen of the the many that we can consider, I think it's well worth it to try to get a modified triplet versus a doublet. Okay, so I'm just going to show a little bit. Obviously, Darzalex, which is this fourth drug that we're talking about, is obviously one of the more potent new agents. And one piece of good news is that it's now approved as a sub-Q shot, FastPro, and already has picked up in its use in the community. So that is great and is making it much more accessible. So we actually have a first polling question. We're just interested, and we track these things over time. And of all the people who are on the call today, we're asking how many of you have actually had a chance to switch over and use the Darzalex FastPro, yes or no? So if you can just click on that, that would be very helpful. Okay, all right.
9% is a pretty good percentage, Brian.
Yes,
Yeah.
the answer.
That's a short time. That's actually quite impressive.
The answer, the 9%, you're right. This is actually quite remarkable. I think there's been quite a lot of anxiety to get switched over to the FastPro, but within those first 1, 2, 3 months, that is impressive. 9% already. Okay. Well, let's keep going. For those of you who have not gotten it, I think it is something to be considered, obviously. So just to give people the idea of where are we with the quadruplets, it was mentioned that we're waiting for the pivotal trials with the quadruplets. However, we do have the Griffin study, which is shown here, that does show fantastic results and tolerance with the Dara VRD in terms of PFS and overall survival. So we know that this can be a great regimen, but we need that extra data to be clear. In addition, we have similar data with Daratumumab Velcade thalidomide dex on the European side, also showing excellent benefit with the quadruplet. One interesting thing is that this is a new trial in which patients with the slim crab, with the subclinical criteria for myeloma were included. And one very interesting thing presented by Philippe Moreau at ASCO is that those earlier patients did particularly well with the quadruplet. And so this does support the notion that if a treatment is working well, and you give it in that first 6 months, and you give it to patients with early disease, you can really get perhaps added benefit. So I'm going to show 2 algorithms that we end up with for Frontline. This is the algorithm that uses the triplets. And so for the triplets, you can see here, if you're not a transplant candidate, you really have a choice of the VRD or the Dara-RD. For transplant candidates, I think we're still pretty much sticking with the VRD, with or without early transplant or collection or storage. If you kind of broaden the choices to include the possibility of a quadruplet, which could be considered, then you have the option of a quadruplet in the transplant patient as well as in the non-transplant patient. Then you have some consideration to do the transplant or not to do the transplant, which is worth thinking about, and also whether you would use lenalidomide alone or lenalidomide plus a proteasome inhibitor for a high-risk patient as a maintenance approach. And so these are just some extra points to think about related to frontline therapy before we move on. We've had different questions coming in. One question was, when do we expect to see venetoclax in the frontline setting? But I think it's a little bit too soon for that. Tom, do you want to comment on that? I mean, we're going to touch on the Bellini study later, and there certainly was a hope that venetoclax could move up front, but
yeah. So as some people on the call already know, I'm sure, the Bellini trial showed that confirmed that the 11 translocation and 1114 population does extremely well when they're treated with a BCL2 inhibitor, venetoclax, plus a proteasome inhibitor, typically bortezomib and dexamethasone. And in fact, a PFS in those patients versus those just getting a doublet, so triplet versus doublet from the Bellini, showed one of the best hazard ratios we've ever seen, 0.11. Really the lowest hazard ratio I think I've ever seen in the myeloma world.
Quite remarkable, yeah.
Yeah, it will come to frontline therapy. The hard part is it would take a big effort from us throughout the US and probably global to get enough patients randomized on the trial, because it is a subset of newly diagnosed patients. But eventually we'll get there, and that I suspect the PFS for that will be remarkable.
Yeah. Just one of those things that'll take time, but it is an exciting agent that we'll talk about a little bit later. Okay, so
Brian, can I add one comment? Just that
yes.
Algorithm, although I think a very good algorithm, I may just say two very brief things on the prior slide. I do think that the endurance study did not teach us about primarily transplant eligible and high risk patients. So as Tom mentioned earlier, I think considering KRD in the transplant candidate, it is a reasonable option, especially we have some smaller but preliminary evidence in the high risk patient. And secondly, I think we may have de-emphasized a little bit that DRD in the non-transplant candidate is also a very good option. We don't have the strength of the SWOG data, as you've mentioned, in terms of long-term follow-up. But in particular, a lot of our patients who may have neuropathy to begin with or are not high-risk patients, being able to continuously give them the daratumumab and lenalidomide in the longer term may have a benefit too. So I just didn't want to miss those 2 points.
No, very, very good. And yeah, so I think that the endurance trial was a great trial, but I think that people still have questions about, well, what about for the high-risk patients, for example? It is a more potent proteasome inhibitor, and as we've learned how to use it better and with perhaps a once-a-week schedule, etc., it can be an important option. Jack, how do you feel the perception is in the patient community with regard to Kyprolis?
I think there's a belief that it's, despite the endurance trial results, that it's a stronger drug than its comparable Velcade. But they also are very, I think, generally comfortable with using it at relapse as opposed to at induction, where it's different from Velcade.
Exactly.
And they'll go that direction.
Yeah, so that's where we're headed next, as a matter of fact. Absolutely. So let's move forward. There's just a little bit of data on maintenance. We had recently maintenance trials, as you guys know, are very, very difficult to do because it takes such a long time to get the follow-up to see what will be the relapses in the longer term. But we did have recently positive data using ixazomib as maintenance in the non-transplant setting. And so what we have for maintenance right now are obviously Revlimid, lenalidomide, plus or minus a proteasome inhibitor, which we would tend to use in patients who have the higher risk FISH cytogenetic abnormalities, and that could be Velcade or perhaps Ninlaro. And questions have come up recently about the risks of continuing maintenance in the face of the COVID crisis, but as I said, the tendency is to try to stick with what the recommendations are. And so, any strong comments about maintenance? I think that we are all pretty strong believers in maintenance, and I just showed the new data coming out of the Stamina trial where there was an important impact of stopping the lenalidomide maintenance. Joe, what's your feeling about maintenance or ongoing therapy?
Thanks, Brian. Yeah, and I'm glad you showed that study from Stamina. I can't say I really believe the aspect of double autologous transplant. I think you have to look at intent to treat. If you look at who got the treatment, it's favoring people who are physically well and healthy and able to go through a second transplant. So, but the second part of it I think was valuable was that there's some of us who are thinking, well, once you've gotten 3 months of lenalidomide, maybe we can just stop it. But I think the added benefit there was seen if people were able to continue it. However, and I write however in the largest capital letters that I can, is that when we're treating people over long periods of time like this, it's so important to be respectful of their quality of life, to speak very carefully to our patients about what side effects they're having, because a lot of patients, at least a third of patients, if not half, cannot remain on lenalidomide for years at a time. And it's not worth making patients suffer. And that's why I think you've well noted below stopping for intolerance. And we have good studies showing to us that sometimes it's not even the lenalidomide, it's the dexamethasone if people are still taking that. And I think it's so important that we down the dexamethasone.
So Joe, there's a couple of questions coming in on the chat box here. One of them is something that we don't talk about that much anymore, which is the risk of second cancers with ongoing lenalidomide. I don't know if any of you want to comment on that. And then using a proteasome inhibitor instead. And then also, if you're on maintenance and you achieve MRD negative, are we comfortable to say that someone should stop? So a couple of points there.
Tom, do you want to start?
Whoever would like to jump in on that.
Yeah, so those are a lot of questions in one, but I would echo what Joe said, and really every study that has looked at Revlimid has come up with more always tends to be better. So a German study where two years versus less than 2 years, better with 2 years. This Stamina now, more than 3 years or stopping at 3 years, more than 3 years seems better. So unfortunately, every study that we actually look at, or even evaluation or analysis that we do, more seems to be better. That said, there are side effects. So I tell people, if you can tolerate more, let's do it. If you can't, then quality of life ends up being, in my mind, more important. Certainly, the wealth of the data is with Revlimid or lenalidomide, and Activism it's an okay drug to use, if you can't tolerate lenalidomide. But I would say lenalidomide is certainly the drug of choice. In terms of secondary cancers, Antonio Palumbo has shown this many times that despite more secondary malignancies in the arms of these studies where people are randomized to Revlimid or not, the people who get Revlimid always live longer. So despite these secondary malignancies, they typically are treatable. A lot of them are skin type cancers, and that wouldn't persuade me to not use Revlimid. So, you know, I would say my recommendation is to use it as long as you can.
There you go.
Brian, I would add to that,
let's stick with that.
I agree with Tom. I do think one of the things that the second primary malignancies has taught us, though, is that it is important for cancer patients who are living longer now to follow the usual routine that sometimes gets forgotten when someone has myeloma, that they get their colonoscopies appropriately, that they get their screening mammograms appropriately.
Very important.
If they see something on their skin, they be followed. Even in our hematology oncology community, when a myeloma patient has a drop in hemoglobin that doesn't fit with their myeloma, we have to look for myelodysplasia. The last comment that came in, or question that came in, Brian, was about MRD negativity. And I know you're really the world experts on this, and you can comment more, that we all are learning that, and no surprise, the deeper the response, the better people will do. But what we don't know for sure yet in the maintenance setting is if you reach MRD negativity, should you stop or not? And thankfully, we are doing studies that compare, you get to a certain depth of response and you randomize then, should we stop or continue, and see how those two groups do? Because there is that tendency to think, oh, sure, we've got an MRD negativity, we may as well stop now. Why would there be benefit of going more? But we know that in certain groups, like high risk in particular, they actually do benefit of staying on. So it isn't as simple an algorithm as that. But I do think with time, hopefully we'll get to a stage where we'll be able to identify the patients who will be able to stay in remission without more treatment. Because my favorite drug is nada or nothing. I would love to have people stop at a certain point.
Yeah,
I don't think that
it would be great.
Forever.
Yeah, but we still don't, as you say, we still don't know that we can do that safely, even if you turn out to be MRD negative. Okay, so we're going to move forward now into relapse, and this is a situation for many patients with myeloma where they want to know, okay, so I went through VRD and a transplant, what are going to be my options now? And many patients are anxious to know that right from the outset, as a matter of fact. And so I'm going to just show a couple of more recent studies. One option is obviously if you've had Revlimid, it would be great to have a regimen that does not include an IMiD. It does not include Revlimid. And so there's been quite a bit of interest in this combination of Daratumumab with Kyprolis and Dex. This particular trial, the Candor trial, was released recently, and actually this combination will probably be getting official approval from the FDA rather soon, I think. But the combination IMiD-free is certainly a very interesting option in a backup position after Revlimid. And so it's a new combo. It's active in standard and high risk. It's IMiD-free. And now the schedule can be with the weekly Kyprolis and now Dara sub-Q. So it's not quite as challenging to administer this particular regimen. And so we do have a question here. How many people on the call have actually used this new combination, which has been possible for quite some time to use this combination? And I know that a number of experts have been using it. So how many patients have actually received this particular combination? All right, so 5%. 5%. Okay. So more people are taking sub-Q Dara, but anyway, that's interesting that it is getting some use out there right now. And if it gets official FDA approval, then perhaps the use will go up as an option in this type of situation. The other data that came out recently was the chemo regimen, the isatuximab, which is the alternate to Daratumumab combined with carfilzomib and Dex, and obviously showed a significant benefit with the ISA KD versus the KD doublet. And so these are just a couple of newer pieces of data. And obviously, the isatuximab also got approved and has this name Sarclisa, which we all love. It's an alternate monoclonal antibody. It is well tolerated by IV infusion, and it's approved in a combination with Pomdex, actually, which was the original trial that was submitted. So this is definitely an excellent option to be considered. And so now I'll be interested in the discussion. There's a lot of discussion about how to approach the early relapse situation. And the main discriminator is have you become refractory to lenalidomide? And are you actually refractory to lenalidomide? Often we're not very sure if you've been on a lower dose of lenalidomide maintenance, are you actually refractory or not? And so you'll see here on this slide, and perhaps I'll just leave this one up as we talk about it to see, well, what would be the favorite options of you guys for refractory to lenalidomide or not refractory. And so maybe Tom, you'd like to start with this one first. I know you've got a particular interest in options in the relapse setting.
Yeah, thanks, Brian. So I would say the majority of patients in the US, and especially the ones in San Francisco, we do use lenalidomide as maintenance therapy if they've had a transplant in the post-transplant setting, and even if they haven't, once they're done with their 8 to 12 cycles, we'll often put them on Revlimid maintenance. So most patients are on Revlimid when they relapse. And when somebody relapses at that point, and they've had a proteasome inhibitor, they've had an IMiD, I think the best thing to choose at that point in time is a monoclonal antibody. We usually use a monoclonal antibody as the first relapse type.
So you go straight in with that. So
yeah,
forget all this.
Well, we do actually, yeah. So and it's Daratumumab has really shown such impressive results for early relapse. People can be in remission for as long a time in their first relapse as they can with their initial therapy using Daratumumab. Pretty amazing. And you can use at that point in time Daratumumab with Kyprolis, like you just showed all the data, or Esotuximab plus Kyprolis, not approved yet, but soon. Or the Daratumumab plus pomalidomide. We select the next generation IMiD, and those drugs or those combinations actually have really wonderful responses, and I think are well tolerated.
Yes. So Jack, what's your thinking about some of these options?
Well, there are a lot there. Yeah, there are a lot of options there, and listening to this discussion reminds me how important it is for patients to get a myeloma expert on your medical team. Earlier, Dr. Mikhael talked about the fact that, well, we can change dosages and we can swap out meds, but most patients go to community oncologists, and the community oncologists tend to follow pretty strictly, in my experience, the results of a trial, and they're not as comfortable with those dosage adjustments.
Right.
And so I think it's really important to get that second opinion, be part of your team.
Absolutely. So Joe, I know that you have had some experience with that Candor regimen, for the Rev refractory, but what's your take on this?
Yeah, so let me first say thanks, Jack, for saying that. I mean, so much of my practice is consultative now, and that's exactly what I try to do, is support the community oncologists, the patients who are being cared for by them, by facilitating that kind of discussion. It's so important because this is the devil in the details now. I actually agree very much with Tom's strategy, Brian. I wouldn't diverge from it much. I would say that the way this is laid out here, I would absolutely not have PVD and DVD as the top ones. Mostly for the reason that even you described in your SWOG study, is that at first relapse, again, I always think of it as the 1-2 punch. Your first line therapy and your second line therapy together are so critical to the long-term prognosis of the patient that when we use Velcade in that setting, although of course a great drug, we're limited by the toxicity. They tend to be shorter use. And that's why right now the #1 regimen in refractory to lenalidomide regimens is the DPD, Daratumumab pomalidomide dex. I think we'll see DKD increasing.
Yes. Okay.
So I think that's
getting a thumbs up there. Okay. Yes. So this, as you know, this is the Mayo Clinic algorithm. But so we'll get some feedback to Vincent about this.
I love Vincent. He was the one who hired me to Mayo Clinic, so I can't say anything about Vincent.
Yeah, don't tell Vincent. Don't tell Vincent.
All right. So let's keep going forward there. Yeah. So we've been talking about that. I don't know if there's any. I'm checking to see if there's anything coming on the chat box about this. Nothing too striking, really. So let's keep going into what's a very, very important area close to Tom Immune Martin's heart, is the immune therapies. And there's obviously 3 main groups right now: the CAR T cells, the bispecifics, and then the antibody drug conjugates. The new Benref, the GSK molecule, just got approved. And so I'm just going to take you briefly through some of the main data for those 3 groups, and then we'll talk about them. So obviously, the Celgene, now the BMS product, the iCell, what we mostly know BB2121, a BCMA targeted CAR T approach with a single arm approach against the myeloma. This slide illustrates that as you move up to the targeted dose, the 450 times 10 to the 6th dose, you do get better responses. CR going from 25%, 29%, 39%, and so definitely a dose response. And then as you go to the next slide, you can see that the patients who are that green color, the ones that are getting the deeper responses, then they have longer remissions. Don't know what's happening there. Anyway, there are deep, durable responses. However, I would say, even although that is sort of the jargon, you'll do notice that these graphs do drop off a little bit as you go out beyond a year, and the median overall is right around 11.8 months to a year, and using the target dose. So I say tolerable, we've learned a lot about how to use CAR T-cell therapies, these engineered T-cells, which have allowed us to be aware of the dramatic early responses, the potential for early serious toxicity, and the like. The second CAR T-cell therapy, which is moving forward, obviously the BB2121, those data have been submitted to the FDA and are under the review right now, and it's hard to know the timing, but there will be the first option to have that approval come later this year or maybe early next year. But the other product, which is actually the original Legend product that was tested first of all in China. So we do have some longer term experience coming from China, but obviously when Janssen took over this product, JNJ 4528, they clearly wanted to have an additional experience, and so the CARTITUDE-1 trial provides that extra experience and really quite impressive results that were presented at ASH, and then more recently at ASCO and EHA by Dr. Durie from Mount Sinai in New York, who actually did an excellent job with the presentations of these data. And so she showed that all the patients actually have some degree of response, with a high number having VGPR and 86% having stringent CR. 2 points are shown over to the right, which is that you do have some persistent and ongoing achievement of MRD negativity. However, you can see up at the top that MRD negativity doesn't necessarily persist, and so that even in this case, where there was some striking deep benefit, we're still trying to learn how long these responses will last. There are other CAR T products. Second generation, one was presented at ASCO, the Evolve, with quite promising results. But I know that Tom in particular is very, very interested in all the different types of next generation CAR Ts and what we will be moving towards in the coming years after probably the KARMA data and the CARTITUDE data lead to approvals for those couple of initial products. So in addition to that, targeting the BCMA, so the B-cell maturation antigen is obviously the receptor on the myeloma, which is targeted by these therapy and is a very, very attractive target, which is present on the majority of myeloma cells in a intense fashion, and so very, very attractive target. Now, if you have an antibody against the BCMA, you can actually create a mixed antibody, which is partly, in this slide, green and partly blue. This is slide 44, and so on the one side, you can have the green part of the antibody that tags onto the myeloma, and then you have the blue part, the CD3 part that tags onto the T cell, which does a couple of things. It triggers the T cell to be activated and also increases the expansion of the number of T cells in the microenvironment around the myeloma. And so you have like a double attack against the myeloma, the direct anti-BCMA effect, and then also the impact coming from the T cells. And so Saad Usmani presented these data recently at the mid-year meetings, the virtual meetings, and again, what you see here is that you get deep responses with ongoing deepening response as you continue with this therapy. So this is ongoing therapy versus the CAR T therapy, which is good and bad. I mean, I think that it's off the shelf, but there is a need for ongoing therapy versus the decisive frontline treatment with the CAR T cell therapy. And then finally in this segment, we have the other type of agent, the BCMA antibody, which is linked to a drug. And so there are two things here. Number one, you have the antibody, and then number two, you have the drug, which is imported into the myeloma cell, and you have a double killing mechanism to attack the myeloma. And so obviously, there have been very good results with this, and recently the combinations have been the protocols that have been presented combining the belantamab with, in this case, bortezomib and dex. Very, very good results in combination, and so this is very attractive for the future. There is an acceptable safety profile, although we do have concern about how to manage the irritation of the eyes, the keratopathy, and I'll be interested in our experts' thoughts about that versus the fact that we can get ongoing, deeper responses with this off-the-shelf anti-BCMA product, which has just recently been FDA approved. And so we have the trade name Blenrep. I'm not sure where they came up with that one. Not my favorite. But anyway, it's an anti-BCMA drug conjugate. It has the advantage that since you have the drug there, you could get some potent effect even if the BCMA level on the myeloma is perhaps a little bit lower. It does recruit that anti-myeloma immune response in the microenvironment. It's off the shelf. I say broadly the corneal toxicities are manageable, but it does require careful monitoring and dose schedule adjustments. One big advantage is that it does seem to be excellent in combinations and is now FDA approved. So a lot going for it there as the first approved agent with the BCMA target. And so Tom Immune Martin, I mean, we'll turn it over to you for your thoughts about, you know, where is all of this immune therapy going? We've got these three different kinds of pathways. How do you see this evolving?
Yeah, thanks, Brian. It is really amazing that these three classes of drugs are going to change the way we treat myeloma. Right now, it's going to change the way we treat relapse and refractory myeloma as we're going to think more about what therapies in the sequencing of therapies. I'll start with belantamab because you just finished with that. And now that it's FDA approved, we have plenty of patients that have already received CD38 antibodies and proteasome inhibitors like carfilzomib and bortezomib, and also IMiDs. And they need another therapy, and this is a perfect therapy for them to try. It's given IV every 3 weeks. It has to be given in concert with an ophthalmologist. Patients do have to go to see ophthalmology regularly while they're receiving this treatment. And you know, the toxin, the poison leaches off this component and actually can get into the fluid that bathes the eye. And about half of the patients, so 50%, will have symptoms enough that they have to either have their dose held or their drug dosage decreased. So it requires manipulation. The interesting thing is people who have had a response and have some ocular toxicity and you have to take a break from therapy, those responses have been durable. It's pretty amazing. They actually have lasted quite some time, even while they're off therapy, waiting sometimes for their ocular symptoms to improve. So far, everybody's ocular symptoms have improved. And even patients that I've treated that have these ocular symptoms, as long as they're having a response and they see the benefits of this drug, they're very willing to continue it, especially at a lower dose, so we can get to a dose that's better. I don't know if Joe or Jack want to say anything else about belantamab.
Right, Joe.
I would just add, just for clarity, Tom, I completely agree with you. I mean, this is a very accessible, will be easy to deliver compared to CAR T and the immune therapies that require, some degree of monitoring and almost hospitalization in certain situations. Here, it's going to be easier to administer. People do need to see, actually, it's not necessarily an ophthalmologist, it can be an optometrist as well. So optometrists are being trained in this area as well. So people, because sometimes it's really hard to get into an ophthalmologist. We hope that a lot of our community optometrists will be brought up to speed, but everybody is going to have to see that eye person, be it an ophthalmologist or optometrist, prior to each dose. But I do think it's going to have a significant impact.
So Joe, yeah. So Joe, that was a question that came in. There's a question coming in here. Yeah, how often do you need to get the eye exams? But obviously, as you just said, before every dose, you need to double check what's the eye status. Yeah. Correct,
because they'll be keeping a record of that issue that Tom mentioned. But I do think it'll have an impact, especially because it will be important to be able to leverage that BCMA. And Tom, when you come to your comments in a moment, and I'm sorry that now I've called you Tom Immune Martin, that it's sticking. But I'll be interested in Tom's view of, if someone has had, now that we're going to see a lot more use of belantamab, can someone still later get a CAR T or a bispecific therapy? Because early in the trials, of course, we disallowed this, but of course now it's becoming more prolific, and it looks like we can. But I don't want to put words in your mouth, and I want to let Jack comment if he has comments about belantamab.
Right. I just want to comment. There's another question come in. So the eyes get irritated. It's like little corneal blisters, which may cause no visual problems or minor blurriness, and often doesn't even cause any pain. But those are the things that we need to watch so they don't get worse and allow time for them to go away. But maybe what we'll do is, Tom, several questions are coming in about the sequencing, so now we have the Bela, which is approved, but how do we really think about how these different agents are going to sequence over time?
So these are really, advanced and wonderful questions without great answers. So let's talk a little bit about CAR T cells, because that's, with the biologic license application submitted for ide-cel, it is going to be in the next 3 to 6 months that we will have access to CAR Ts. Now, I will tell you that just what Joe said before, and also Jack said before, your local docs are not going to know about CAR Ts. And to get an opinion about a CAR T or whether you're a candidate for a CAR T therapy, you do have to come to a myeloma specialist. That is the most important time to actually come to a myeloma specialist. Is that going to be part of your therapy? So, the way I describe the CAR Ts, greatest advancement and almost most depressing results, right? We all hoped it was going to be curative like it is in lymphoma. If it's gone for 3 months, it'll be gone forever. But what we're finding is that patients on average are in remission for about a year. And they're off therapy, which is amazing. But over time,
so we have this.
Over time, slowly but surely, it does come back. So we have to make better CARs. And we probably are not going to be able to do it without some form of maintenance-based therapy afterwards, or some consolidative therapy afterwards. We're figuring that out. We're going to have trials to figure that out. But for right now, CAR T cell therapy, when I ask my patients who've had CAR Ts, we've done about 50 to 60 at UCSF. I ask them, what was harder? Was your autologous transplant harder, or was your CAR T therapy harder? And almost uniformly, they all say, oh, the autologous transplant was way harder. So I actually think some people who may not be a candidate for an autologous transplant can still be a candidate for a CAR T cell therapy. But like Joe said, right now, that is requiring a hospital stay. And we keep people about 2 weeks. We keep people in San Francisco for about a month. Again, you'll learn this information when you go for a consult, et cetera. these are extremely exciting. You know, the Janssen, the J&J 4528, which you saw the waterfall plot where most people's disease just got wiped away.
Just amazing, right?
Unbelievable. And the PFS at about 7 months is still over 90%. So whether that's going to really have a better PFS than the BB2121, hard to know. I'm a little optimistic that maybe we're going to have even a longer remission duration with this CAR. But again, we still have to do better. It'll be probably a year before that one is available and on the market. But CAR T cells are certainly here to stay. They may be applicable to a larger population of patients than autologous transplant, but you still have to come to the center that does them. That's the hard part, and you got to stay there for about a month. Other thoughts, Joe and Jack, on CARs?
Yeah, so maybe Jack, give you an option. What are your initial thoughts about CAR T and the immune therapies?
So I've had patients ask me after listening to talks like this, wow, they're working on 2nd generation and 3rd generation CAR Ts. Should I be waiting if I have the option rather than go to this Karma CAR T that will be approved within 3 to 6 months? And then I've also had them ask me, since both CAR Ts, most of them, and the blend rep, ADC focus on BCMA, how will doctors suggest one over the other?
Right.
Yeah, if I can jump in on that, Brian, I mean, that's
sure, please.
Two of the most important questions we have. And it goes back even, Brian, to what we said around frontline therapy, that we don't have a one size fits all. That when I look at my individual patient, like Tom said, paradoxically, I might have a patient who is not eligible for transplant, but I think may be good for CAR T. I do think that as we get more experience with these drugs, we will be able to find the right combination and the right approach with patients. But in the short term, Jack, you asked a really good question, which is, what do I do right now? And I think there's always an argument to, do we go with what's, FDA approved, tried and true? We give you selinexor, we give you belantamab, or do we go towards a clinical trial? And one of the benefits of going to a trial is that you can still always come back to what you have in already FDA approved pocket, as it were. And that requires such an important discussion with patients. I do think that Tom made a critical point that we are going to make, as he's walking away from me, we are going to make
Tom is off for a minute.
Better CAR Ts. I do think that one of the things, Brian, you showed this. Yeah, nice shorts, Tom.
Yeah, very good. Yes.
One of the things that we've seen this with every wave of myeloma is that we get drugs, as we learn more about them, we get better drugs that are not only better because they're more effective, but because they're safer. I mean, the very first CAR T study in myeloma, tragically, 3 out of the first 9 patients died. So we're far away from that. So I don't want to ever discourage people from going to a trial, but yes, I do think CAR Ts in a year and 2 years from now will be safer and more effective. But I don't think it's going to be one or the other. I think you match it to your patient, and we will be able to sequence some of these. I do think there are people that will get belantamab and then can later have a CAR T, and then even later will have a bispecific antibody.
Okay, so we're going to have to keep moving forward here. But Tom, if you could just make some brief comments about the positioning of the bispecifics, if you think that really is going to be an important group of where some patients will particularly benefit, perhaps, or what do you think?
Yeah, so the bispecifics, and again, these are antibodies where one arm anchors itself to the myeloma cell, and the other arm is looking for the T cell or the immune cell in the environment, grabbing a hold of it and activating it right there. And it's been incredibly successful. And the response rates for 3 products now have been over 60% in a really refractory population. I have patients that have been on these drugs as a part of a research trial now for over a year and remain in remission and are MRD negative. This is probably the class of drugs for me that is the most exciting, because I think we're going to be able to use these easier throughout the entire myeloma paradigm. I think they're going to be used in smoldering myeloma, newly diagnosed, early relapse, and late relapse. So these, and there's about 20 companies, right, Brian, or so, that are investing in.
Absolutely. Amazing. The administration is a bit challenging, though, because you need to have ongoing administration, right?
It is. You have to keep coming back and forth, but some of them now are giving therapy once they're in remission once a month, so every 4 weeks.
Okay.
So it's
Makes
once
it
a month.
Easier. Right. Okay, so let's move forward, and I'm sure there will be more questions about this aspect, and we'll have time later. So as you guys know, and most of the patients know, there are also other novel therapies, maybe not quite so sexy as what we're talking about, but nonetheless quite important and quite active. And so we need to look at those. So one is the group of drugs, the cell mods, which are basically drugs coming after the IMiDs, a slightly different mechanism of action, but in that same sort of IMiD category, and also developed by Celgene, now BMS. And so the Celgene 9248, these are data that have been presented a few times, basically showing that this type of a cell mod, which is an oral agent, does work in patients who have previously received Revlimid or pomalidomide. So in the IMiD refractory type of patient, which is quite interesting. And there are several cell mods, actually. This is just one of them. Another interesting agent that you guys can comment on, there is a registration trial, the Horizon trial. Paul Richardson is the lead investigator for this particular agent and is leading this trial. And basically, it's a unique type of melphalan where the melphalan is incorporated, the melphalan flufenamide is taken up into the cell, and so it does have an interesting possible option for therapy in refractory patients. So you guys can comment on what you think about the status of these ongoing studies. It will be submitted for accelerated approval. And then obviously now selinexor is approved, and we recently had the results of the Boston trial combining selinexor with Velcade-Dex, and obviously the triplet was better than the combination, and possibly the selinexor was a little better tolerated even in the triple therapy. And so selinexor is approved. It's a unique mechanism. It's oral and convenient. It does have unique side effects, which talk about needing an expert. I think that in this case you do need some expert advice to manage the side effects, but it can be broadly partnered, and obviously we have the Boston data to support that particular combination. So I'm interested right now, selinexor has been approved for a number of months now. So how many patients have been taking selinexor? We'll see. I don't know. We don't know. Oh.
A small percent right now.
Yeah, a small percent for some reason. Okay, look at that. Only 1% of people on the call have taken selinexor. Interesting. Okay. More people have taken sub-Q Dara.
Wow. Yeah.
Okay, well, we're going to keep going here because we have a few other things to get to. We've had some good discussion so far. The other agent is elotuzumab, and actually the elotuzumab was used in a SWOG trial along with VRD to see if it would enhance the outcomes, which unfortunately it did not. However, elotuzumab is approved in combination with Rev-Dex, and also has been used in combination with PalmDex with kind of excellent results. It's well tolerated, which is a big example. The results with Aiello PalmDex were actually remarkably good in this kind of resistant setting. Then we've touched already on the venetoclax, which was really impressively active for patients with the 1114 translocation in combination with Velcade Dex. So very promising, although we're kind of waiting to see what will be the development path forward. And so just briefly, any thoughts about these additional novel agents? What strikes you as particularly exciting or worthy of comment? Anybody?
All right, Joe, you go first.
Well,
yeah, Joe goes
first. Careful what I say about Tom Martin these days. No, but I mean, I think, Brian, despite, as you said before, the sort of the sexiness of these immune therapies that we just discussed, I mean, we're still not curing myeloma yet.
Right.
Susie said it correctly at the start. We're reaching a fraction of patients, but we want to cure obviously so many more. And so it's good to have more options. I know I've been saying this repeatedly today, but having different options for different patients is important. I'm a little surprised at the selinexor numbers because this is a drug that can be very potent. Yeah. But you're right, and Jack said it well, you know, this needs to be in the hands of someone who's comfortable with it. I speak to oncologists in the community literally every weekday about how to give selinexor, because if this drug is given in the right context, it can be very effective. If it's just given to the patient, sent home, come back in a month, almost every patient is going to quit because it really can have some strong side effects. I do think that it'll be a lot more feasible to use, like you showed in the Boston data, when we use it in combination, whether it's bortezomib or as you now it's been studied in almost every other drug. So I think selinexor in this list is going to have a greater impact in the short term. And then lastly, and I'll leave the other two to comment on the other drugs. As for the melflufen flufenamide, also known as, or melphalan flufenamide, also known as melflufen, the artist formerly known as melflufen, there's the melflufen.
There we go. Lots of floofing.
There's a part of us that feels like, haven't we gotten past melphalan now? I mean, haven't we got? But that class of drug is still very potent, and if given in this way, where it's less toxic and arguably even more effective, and ironically, we have a lot of patients now, especially transplant ineligible patients, who've never seen melphalan after multiple lines of therapy. This could also have a significant niche in that sense, and it's also starting to be used in combination. So I get excited, Brian, when I see lists like this, because I know not every drug is for every patient, but we can tailor them.
Very, very good. So unfortunately, we're going to have to move forward because we've had a lot of different good discussion here. And so just to show this slide is that there are a lot of options in these different relapse settings, including these novel agents that we've just touched upon, including the melflufen there. And we have a lot of expectations about approvals as we move forward. Bella just got approved. CAR-T probably next, and then melflufen also in that same category, maybe a bit later on. And so we have a number of things that we have we're looking to see happen in the coming months and year or so. But I'd like to move forward because I don't want to give short shrift to what is something that's very, very important, which is particularly right now with the COVID-19 crisis. How are we focusing on not just the patients, but the caregivers? And so I want to give plenty of time for Susie and Robin Toohey, who will be joining her on this to talk a little bit about caregivers. So, Susie?
Thank you very much, Dr. Durie.
I'm happy to advance the slides.
Thank you. For those of you who might not know me, I've been involved in myeloma for over 30 years. I never thought I would become involved in multiple myeloma since I couldn't spell it and I didn't even know what the heck it was. But what happened was that we knew that we could make a difference for patients and their families if we worked together collaboratively and if we could just give everybody chance to just take a breath we got this, we're here for you. And caregivers are very, very important. They do all the things that other people just aren't able to do, whether because they're busy or they're too ill or they don't have any support, or maybe their families aren't near them and so forth. So we really consider holding a caregiver meeting. And a lot of times people say, what I wish I'd known when my loved one was first diagnosed. And it's amazing to then have to realize these people, they get a diagnosis, they can't even spell it, they don't know what the heck it is. All they know is that they're terrified and how do I get rid of it? So we conduct regular meetings with both patients and caregivers and let them share their concerns. Contact the IMF. We're open, I want to say 24/7, but we're open pretty much all the time.
Yeah.
Support group directors are also available to do a virtual caregiver meeting with support groups. And Robin Toohey is one of the ones that does an awful lot of that. So I just want to have a quick question. Robin, you want to do the polling?
Yeah, so we're thinking that people on this particular call, we're thinking that many of them will be currently part of a support group, but we're just about to find out. So if you're currently part of a support group, let us know, yes or no.
Are you Robin? Okay, that's the polling begin.
Yeah.
Yes or no? Are you part of a support group? I hope you are. And if you're not, we'll get you in. Okay.
Let's see what we have here. All right. So 58%. So we know the sort of patient that we're focusing on for this call today. So 58%.
And I would encourage the people who.
Okay. What? No, sorry.
No, I would say that I would really encourage anybody who's not a member of a support group to join a support group. It makes a huge difference, and it allows you to take a breath, relax, I've got this, and share with other people. It's very, very important. So, Robin?
Yeah, Robin, if you want to pick up a little bit here with the special support for caregivers right now related to COVID-19, I think this is very especially helpful.
Yeah, sure. Thanks, Susie. Thanks, Dr. Durie. A lot of these questions about the caregivers came from a survey that the IMF did with support group leaders. And caregivers really have a lot of concerns, not only for their loved ones and learning as much as they can about multiple myeloma, but now we have this extra anxiety and stress about COVID-19, of course. So people were talking about how do we keep our loved ones safe when we go out and we do the groceries or we have things delivered into the house. So of course we've been hearing all of these different things. Back on slide 67, if we could do that, all of these suggestions about washing our hands and the 6 feet distance, social distancing. And Susie, you always have such a good analogy about how important it is for caregivers to take care of themselves. Do you want to share that?
Absolutely. So it's kind of like when you get on a plane and you have to buckle up and you have to sit down and everything else. Well, especially when the mask drops down when you're on the plane, you know then that you really need to take good care of yourself. That's kind of like what we're saying to all of our caregivers, and you really have to take very good care of yourself. And a lot of times people feel like I'm so overwhelmed, I've got so much to do, I don't have any time for myself. And that's when Robin and I say, yes, you do. You have to carve out that time. Just, close the door, lock the door if you have to, sit down, either rest, listen to some music, maybe take a walk. But you've got to get out of all that stuff that's swirling around you and get into some place where you feel safe and you feel, okay, I can do this. I can get up now and I can go back out there and make it happen.
Right. So Robin, you want to pick it up? Obviously, support in going into a doctor's appointment is particularly important right now if you go or if you don't, unable to go.
Yeah, absolutely. So I think one of the most important things that we as caregivers can do is take advantage of our cell phones. We know Dr. Joe and Dr. Martin, you all have your cell phone probably in your pocket right now, if not right next to you. And so when our patients, when our loved ones, when our loved ones are going into the doctor's offices, and now because of COVID-19, the caregivers are not always allowed to go up into that appointment with them. And it is challenging, and for multiple reasons. Sometimes the patients don't always express maybe all the pain that they're having or all the side effects that they're having. And the only way to best manage the pain and the side effects is to be honest and to have those conversations. And I think that's where the caregivers often will jump in and say, hey, doc, he may be telling you this, but in the real world at home, here's what's happening. So for the caregivers to continue to be an active role and having this communication back and forth is so important. So bottom line, talk to your doctor and say, hey, I want to use my cell phone when my loved one goes in there for the appointment to make sure I'm part of that. And step two, the second bullet, to me, this is almost, if there could be a silver lining of COVID-19, telemedicine today has become really a wonderful tool that we can use. We've heard each of the doctors, as well as Jack Aiello, talk about the importance of second opinions. And now, if you live in a rural area, and maybe you weren't able to get in for a second opinion with a myeloma expert or one of the doctors that sees myeloma more often, or 100% of his patients are myeloma patients. And Dr. Joe, you had mentioned earlier that the experience helps to match the best treatment to patient comorbidities. So when we're trying to make these decisions along with our team, right? Because we should always have our healthcare is a team effort. And when we're thinking about this team effort, we want to make sure that our doctors know these intricacies of not only the drugs, but our own comorbidities. If you have high blood pressure or peripheral neuropathy or heart issues, and Jack, you know, in support groups, we hear this all the time. How do we know which drug is best? Well, let's use these telemedicine appointments now when most insurances are covering it and get these second opinions.
Definitely.
Yeah, very, very good. Yeah.
One of the things that I find often is that a lot of people who go to their doctor, they're intimidated by their doctor and they're afraid to speak up. And we try to really encourage them that that's not the way to go. You need to find a doctor that's going to work with you and is going to listen to you as much as you're going to listen to he or she.
Right.
And we've had people come in and say, you know, after a visit with a doctor, I just went to see my doctor, and I started asking him questions, and he told me if I wanted to answer his questions, you should make an appointment. And then the little woman said, I did make an appointment. It's right now. So these kind of things happen, and it's not just once in a while. A lot of people are afraid to really speak up to their doctors,
right,
and to really let them know what it is that's bothering them, and you know they want answers and they want some support.
So, Robin, do you want to walk us through some of these special situations here, like visiting grandchildren?
Yeah, so this I have to give Jack Aiello on the call with us today. I have to give him big props because he shared this with me, and we're friends on Facebook, and I saw the picture that we're looking at here, and it warmed my heart because when I'm talking with support group members, I hear all the time now, people are really missing their families. They're missing the social, give a hug and all of that stuff. So Jack's wife now, she came up with what I think is such a fun way to stay connected and to stay safe while we're being at a distance. right? So Nell has a Skype visit with her children and grandchildren. She picks out a favorite recipe. Jack, I think this one was some red velvet cupcakes. And I think, Jack, you told me
Okay.
that's your elbow there in the picture. So you really were helping out. And I bet you were eating more cupcakes than you helped to make, though, right, Jack? But also, I think the message here, too, is, Dr. Durie, we've talked about who is in your bubble. And what does that mean? So people that are doing similar things to you by staying safe. Are they wearing masks? Are they, taking all the same precautions as you are? So think about who is in your bubble and who can you maybe have that small gathering with, maybe outside in the backyard, get together and continue to be safe. We need to have human interaction, right? That's who we are as people.
Yes.
So
people in your bubble.
Slide, right, your bubble. Know your bubble. So this slide is fun because this is my backyard, and we were really missing seeing our children. Our children are adults now, and they are in our bubble. But what we did was we bought this huge blow-up movie screen, and we put blankets outside. We're all distanced, far apart from each other, but we have a blast. We pop popcorn. The dogs really love it. So think about those things in your life where you can live your life well, even with myeloma and COVID-19. So Susie, take it away here.
Next one.
Well, I have to say that you have to just kind of you just have to roll with the punches from time to time, but then get up, dust yourself off, get going, and do things that make you feel good, that make you feel that you're important, and most of all, never, ever give up. Never, ever. I mean, once in a while, you can just have a good cry. I would have a good cry, like lie down on my bed and sob, and then myself would say to myself, get up, get out of bed. That's enough. 10 minutes, get up. And things like that really do work. To allow yourself to just have a meltdown, but, don't wallow in it. Get up, dust yourself off, and keep moving.
And give yourself a hug.
Give yourself a hug. Right.
All right. So that really, I think, is incredibly important just to pay attention, and especially right now when it's so difficult to have the social connections that we're also used to and that we really rely on, depend on. So, Dr. Joe, we're actually running a little bit behind time, but we can just, Tom has been stretching off and on, but we can just stretch, we can just stretch slightly here for a minute. Just take a minute to stretch and maybe just step up for a moment, and we'll maybe keep going here. Joe is off for a minute. There you go. That's fine. Yay. And then we'll get started. So the last part is a little bit of an update about COVID-19. But frankly, things have in many ways simplified in terms of what is it that we can do and we want to do related to the COVID-19. And so for COVID-19, I'm just going to kind of hit the high points, and you guys can comment on what you think is the main impact and any special recommendations that you guys have. So,
Brian, can I just say very quickly that I so enjoyed what Susie and Robin just shared with us. I think that is so wonderful, incredibly valuable. And one thing I will say, in light of the comment I made earlier about dexamethasone, I have learned more about the challenges with dexamethasone from the spouses and the partners and the caregivers of my patients than the patients themselves. So the caregivers have a role not just in supporting per se their loved one, but honestly in delivering accurate information to us. Because a patient is not going to say, oh yes, I get grumpy every Tuesday. after I take my dexamethasone. It's the spouse who looks at us and says, I can't tolerate him every Tuesday. And so it is a really important part of the whole fabric of what we do.
Right.
Yes, and trying to maintain and sustain that with the telemedicine is very important as well. You know, to use the cell phone to link in, etc.
Absolutely, and sometimes we're doing our visits now by video. I get to see a patient and their family or their caregiver, sometimes even their pets, in their context of their own home. And although I'd love to see my patients in person every time, sometimes actually that could be even beneficial.
Well, I think that women can multitask better than men.
Well,
no, you guys are like you're going down but women are like, woo, they're all kinds of things.
Next time we'll have a woman expert on. So we'll
that would be
maybe we'll have Nina Shah on the next time, right?
No, it'd be Robin and me.
Okay, so this is going to be the speed round, just to talk a little bit about where we are with COVID-19, because I think that we're bombarded with this information every day right now, unfortunately. And so obviously, to be really safe right now in many places, including California, but also Arizona and Texas and Florida, I mean, the level of COVID-19 in the community is so high, staying home and staying protected is really quite important. Strongly advocate wearing a mask, physical distancing, and careful hand washing whenever you're out and about or touching any unusual surfaces, if perhaps you go to the grocery store and the like, but also, as we've just been discussing, sustaining social networking despite the physical distancing. It's worth thinking a little bit about where we are in this pandemic. And so it all began back in China late in 2019. It spread to Europe, particularly to northern Italy, and was actually triggered quite a bit by a lot of people having skiing holidays in Austria at that time, and then going back home to Germany and to northern Italy. But then, subsequent to that, the infection actually morphed a little bit and then moved over to New York, as a matter of fact. And so the strain of the virus, which ended up in New York, and is the one which is spreading across the south right now, is one that came out of Italy, actually, is not the original strain that came out of China. Now, we had about a week or so ago, we had a very, very enlightening panel, a roundtable, a global myeloma roundtable, and Joe was on that. And we were asking all of the different experts from around the world, what has happened with your myeloma patients? And so this chart here shows the rather remarkable results. And so the pandemic started in China and spread throughout Asia. However, up to now, there have not been hospitalized myeloma patients. So this is looking at myeloma. What has happened to myeloma patients in Asia? And so in Asia, there have not been patients hospitalized, and there have been no COVID deaths. And so I have a couple of footnotes there. It seems that there may have been one or two deaths in China, but in the centers that we work with, for example, Tom Martin, you've been there a few times, Wandu in Shanghai, for example, and Professor Chen in Beijing, these guys have not been seeing myeloma patients much affected by COVID-19. And nothing at all in Singapore and Korea. So really quite fascinating. And I'll maybe just finish this slide, and maybe you guys could just comment on this because it is pretty remarkable. Now, compared to that, when the surge happened in Italy and then in Spain, a lot of myeloma patients ended up in the hospital. And through the Spanish research team, the GEM group, which is a bunch of like 30 and 40 hospitals, they had 166 myeloma patients that got hospitalized in Spain. And it really was quite threatening that these patients did not do well, particularly if at the time of the infection they had active myeloma, either newly diagnosed or relapsed myeloma. The Spanish team, being the clever team that they are, they did a very nice matched comparison where they looked at older patients who had the same risk factors as the myeloma patients, except that they didn't have myeloma. And what they showed was that if you looked at an older type of individual with some risk factors, the likelihood of having a serious outcome in the hospital was 21%. For myeloma patients, it was 34%. So there was like a 10% added risk related to the fact that they had myeloma that was actively needing treatment at the time. Now, in the UK, where there was just a very sudden surge and the hospitals were completely overwhelmed, actually over half of the patients with myeloma that ended up in the hospital did very poorly. And then if we look at the data coming out of New York, several of the centers have reported their numbers, and it's in this 24 to 30% range, whereas in other places, Joe has told me about Arizona, and Tom, probably the story is still the same in San Francisco. You have not had any patients affected in San Francisco, is that right?
Actually, I think right now we have 2 or 3.
You do?
But this
are
is
infected?
recent. Very recent. Yeah, one in the hospital currently that was taking Revlimid, yeah.
So.
But doing fine.
They're doing fine. Good. And Joe, I think that you had, there were 5 recently, but no patient who actually had done poorly, right?
Correct. Yeah. I mean,
right?
Our patients have done extremely well. I think a lot of it is, of course, our surge was after that of New York and even San Francisco. So by then we had better treatments. There was much more of the precautions people are taking. Of course, our patients already are very educated in washing their hands and wearing a mask and distancing when need be. But we're very blessed that we don't want to see any patients in the hospital, but thankfully we have very few in the hospital and no deaths.
Right. And so obviously in Asia, there are several factors. One of them is that they're very much used to wearing masks. So they were using masks immediately. And then they also had very strict public health measures that were put in place. For example, in Taiwan, they had a rapid lockdown and the like, unlike what we've had here. Okay, so the key message is that right now, especially if there's a surge in your community, avoiding exposure is key because especially if you're having issues with your myeloma, you just do not want to get exposed. There are factors that we know about that can be very important that we've talked about a lot, some of the underlying medical conditions, and obviously the fact that people of color can have difficulty in the U.S. accessing care, things like that, which are very, very distressing. But right now, the key factors that are important, you have to avoid getting exposed, especially if you're elderly, high blood pressure, overweight, diabetes, or chronic kidney or lung disease. These are the things that have been factors in those case reports that I referenced in the publications, and particularly if the patient is undergoing new treatment at diagnosis or relapse. Why is it that we're continuing to have these surgeries and, like Tom was saying, some new cases popping up in the U.S., and it's hard to put a single finger on it, but continuing to have unrestricted travel across the U.S. means that there can be individuals coming into your community that are infected. And then the lack of the ability to rapidly test and trace and quarantine is a problem. The lack of universal masks is a problem. The fact that there have been continuing to be group gatherings has been definitely an issue for all of us, which means that there's a higher level of infection in the community, which means that it's more difficult for us to go out into any kind of social activity. Okay, here, there we go. So I'm going to keep going, and then we'll discuss it at the end just because of timing here. There are some special issues that are extremely important for myeloma patients. And so the first bullet here, I think, is incredibly important for myeloma patients. And that is that if some member of the family or your friends enters your bubble, and so if you have a group of people that you know within your family and possibly some neighbors or something like that, you know them. However, if somebody enters that group of people, enters your bubble, they could be bringing in infection, and then once it comes into your bubble, that's where there could be transmission from a younger family member who's maybe working at the grocery store or maybe went to a bar or something like that. And so you just need to be so careful about someone who might be bringing infection back into your personal or family bubble. And then when you're out and about, these are some things that you need to watch out for, elevators, especially grocery visits or schools. Schools are possibly the hottest topic right now, but really, really important for myeloma families. If some member of the family is going to school, you know, are they going to be bringing that infection back home? It's something that unfortunately you do need to be alert to. When you're going out for the groceries, again, you need to be alert. Are you bringing infection back home? We've talked a little bit about some of the things that you can do to reduce risks during a crisis. Telemedicine is really a good way to reduce the number of times that you need to be out and about. But as we go to the discussion, we can talk about some of the emergency changes that can be made to modify treatments to reduce the risk for patients, limiting or changing the labs. However, you know, if you change the labs, then how do you compare the results with what you've had before? So we just need to be cautious about making changes that will mess up the way that we optimally want to manage your myeloma. We can cut back on the Zometa or Iridia. That's a fairly easy thing because that's not going to have an emergency impact. We can make other changes, and we can delay the autologous stem cell transplant, and there are always a lot of questions about that, and so maybe all of you can comment about what's happened with the autologous stem cell transplants. And then obviously the Darzalex, there was a tendency to maybe cut back to maybe once a month to reduce the number of clinic visits. Yes. So we thought we'd ask a polling question here just to get a sense of how many patients have actually been using this telemedicine approach or the equivalent? How many of our patients on the call today have actually been doing that? Yeah, we have a spontaneous music here. Oh, look at that. So 77% of patients have been using that kind of approach. That's very interesting, actually. Joe or Tom, you might be maybe comment about how much of that maybe will continue later. You know, they'll maybe continue to do the telemedicine, perhaps. Okay, let's keep going here. Common questions, you know, can you go out for a walk? And certainly we do encourage that with some social distancing and wearing a mask. Going to the dentist has been a little bit controversial, although I think that the American Dental Association has put some pretty strict guidelines in place. So I think it is actually mostly safe to go to the dentist. So you might have some commentary on that, guys. So obviously we get bombarded every day with where are we with the vaccines, and I think important questions for our population is will the vaccine work in a more elderly population? Will you need a booster? And that's going to take a little bit of time to know that, actually. So it's important for us to be aware of that. And what about the impact of being immune compromised when you get one of these vaccines? And so I'll be interested in any thoughts about that. As far as particular treatments, it was pretty interesting that dexamethasone reduced the risks in patients with COVID-19 when they had the serious lung complications. Remdesivir, it does seem to be a somewhat helpful antiviral. And also interferon does seem to be somewhat helpful, which is interesting. And the FDA did revoke Mr. Trump's favorite emergency authorization. Anyway, we won't comment more on that. What I did want to show you in closing is a little bit about what is happening with the support groups. With the COVID crisis, there has been an amazing shift where the support groups have been going virtual. And you can see all the happy faces of the people who have been able to connect in these virtual meetings. And you can see at the bottom there, over 90 support groups are now holding monthly virtual go-to meetings. And so it really is quite remarkable that there has been a shift towards this connection and keeping up to speed and really supporting the patients across the country. Yeah, absolutely. And so there's even more pictures, more groups here. People really benefiting from this to keep up with their myeloma treatments and just getting reassurance about how to manage some of these different points about the COVID-19, about the masks, about how to handle getting their groceries or different concerns that they might have had. And so I think for sure this started back in the spring, and you know, it seemed like spring got canceled. Now we're moving into the summer. It seemed like the summer got canceled as well. And maybe the fall's going to get canceled, but I think nonetheless, hopefully we will ultimately be getting through this together. And so we need to get through this complicated situation. This virus is definitely a tricky virus. It spreads in the air, and we got to watch out for it all the time. But standard precautions do work. Wearing your mask, physical distancing, avoiding groups, and short-term adjustments in myeloma care are fine, but we want to stick with the best care as much as we can. Unfortunately, the longer-term impact of this virus still remains a little bit uncertain. But I'm going to stop with that. We have a huge amount of information on our coronavirus COVID-19 page, but maybe I'll open up to our panel first for all of you just to comment a little bit about what do you see as high points related to patients. So maybe Jack, what's your feeling about issues related to COVID-19 right now? What are the important things on your mind?
Mute, Jack. You're on mute.
Yeah.
Yep.
On mute, Jack. You're on mute. He's coming.
Okay, I'm muted.
There you go.
So I think the slides that Dr. Durie presented are the things that all patients are concerned with. I'd like to make one point kind of following Susie and Robin's presentation. And the poll on 48% of folks on this call do not attend a support group. And it could be that the nearest support group is 100 miles, 200 miles away from you, even though they're over 100 in the US. So one of the advantages of the fact that almost all of the support groups are online and doing virtual meetings these days is that you can pick an area that's most favorable to you. Go on the IMF site, find a support group area that you want to connect with, and email the organizer. We just had a support group meeting this morning preceding this call. And we've had people in the Bay Area, and we've had people as far away as Florida be part of our support group, given that they can attend virtually.
Really, really good point, Jack.
I love it, Jack. Thank you so much.
Thank you so much. So you two guys, Joe, Tom, I mean, you could comment on the COVID, or you could comment on more broadly, is fine.
I have three comments. First is,
okay,
for all the patients, control your environment. You can control your environment by not going on a bus, a train, or a plane. You can control your environment in a grocery store because you go when there's nobody else in the grocery store. Get in there,
okay.
get it done, wash your hands, get home.
You haven't been to Gelson.
Yeah, second, you have to do your myeloma therapy no matter what. Yes, you can optimize it, just like Dr. Durie said, and maybe that's why so many people now are getting sub-Q Dara, because it's shorter.
Right.
And that's fine. I don't, at the current time at UCSF, we do not push off people's transplant. If you need a transplant, you need to get it now. Let's get it done. You have to shelter in the hospital for the transplant. You have to shelter when you go home after the transplant. It's a perfect time. You're going to do the same thing that you're going to do anyways. So get it done. And the final thing is what we talk about, is what Dr. Durie addressed, was the vaccines. We're all really looking forward to having some vaccines. I tell all my patients, I'm getting in that line the first thing in the morning, and you can cut in front of me, because I want you to get it. And I want to see if you respond to that vaccine. If you do, great. If you don't, then we're going to have to make other plans on how we're going to make you safe, et cetera. So that's all I'll say at this point.
Yeah, no, really, really helpful. So fully agree with all of that, obviously. Thanks, Tom. And Joe?
Yeah,
Dr. Joe?
Yes, not much more to add to that, apart from just re-emphasizing this point unequivocally, that the greatest risk you have, even for COVID, and unfortunately the greatest risk you have for ill health, is to poorly control the myeloma. I was impressed that our colleagues at UCSF actually never really stopped doing their transplant program, because it's part of the best therapy. And although sometimes we make quick modifications, I agree with what you said, Brian, maybe holding off the bisphosphonates, but I know it may sound paradoxical, but very often going to see your community oncologist or your myeloma physician's office is a safe place. We've made tremendous changes, and many of us now are even structuring the way people come in and out of the building, et cetera. And I think that's so important. And my last point, Brian, is that we can't just think about myeloma. As I say all the time, I don't treat myeloma, I treat people. And within your bubble, as was described, thankfully, there are some things a little bit better. We're not washing down our mail and our groceries anymore. We've come to learn a little bit more about the disease. But I think it's so important that you reflect on your own wellness and what is bringing you wellness at this time, because we can all, hunker down for periods of time, but what is it that you can do? And I know that the picture of the woman walking her dog had her mask on, but there are times and places you can walk outside without a mask. And there are things, as Brian always beautifully says, he doesn't agree with social distancing. He agrees with physical distancing and social connectedness. We need that. We're going to suffer. Our children, our families are going to suffer if we don't allow that connectedness to occur. And it may be through Skype. I want to taste Jack's red velvet cupcakes.
Yes.
But that is absolutely important, because we see this in talking to a lot of our patients. They feel very isolated. They feel very marginalized. They're told, well, you're the cancer patient, so you can't come near anybody or do anything. You have to find in your own life, what is it that's going to bring your wellness through this?
Yeah, absolutely. And so just to point out, emphasize again one point, is that the infection with the COVID-19 is happening in the community. There has been an anxiety. Telemedicine is great, but actually going into the center, that's not where you're going to get the COVID-19, right? So it's a safe place, actually, right? And so please don't be concerned that that's where you're going to get the infection. Most of the time, it's going to be one of the safest places that you could be or go to. Be much more cautious about your personal bubble, about some of these other things that we've been talking about.
And get a dog.
And get a dog. Oh, yes. That was the other part of that picture. Have a dog. But you're right, Joe. If you're out, in a park and there's nobody else around, breathing freely as you walk around, as you do out in the desert in Phoenix. That's wonderful to go for your run in the morning, right?
I do every morning, and it gives me my calm for the day.
Yeah. And Tom, are you able to do that in San Francisco without your mask? Yeah. Go for get some air in the morning.
Actually, there are some counties in the Bay Area that have now started to write tickets if people are outside without their mask on.
Really?
So, yeah, it's not so.
So you need to be
primary, but everybody's
got to be a bit cautious.
Great.
Yeah, yeah. No, that's true here in LA. I mean, let's, I guess, not get too cavalier here because absolutely wearing masks is just so important. Okay, well, I think that we're close to the witching hour here. I think that we can have final thoughts potentially from all of us here. I'll come to you last, Susie. You have the final word, okay?
Oh my God.
So perhaps Jack, any final thoughts? We've gone through all of the myeloma treatments, and the big emphasis that I think we all want to make is that we want patients to be sticking with these best regimens, having access to the new therapies, and have that as their big focus, despite the constraints of the COVID-19. So, any final thoughts, Jack?
You're muted. You're muted.
Oh, Jack, you got to unmute again. Jack.
Just to let you know, the organizer mutes me. I haven't unmuted myself. Anyway, my final thought, first of all, thank you for asking me to be part of this webinar. I really appreciated it. And I can't emphasize and reiterate enough how important it is to get experts like the doctors that are part of this. And there are so many around the country that can help be part of your team. And you honestly don't even have to give them red velvet cake. So
okay. Although it might help. It might help.
Might help.
I thought it was red velvet whiskey. That's what I thought we were talking about.
Yeah. So Tom, any final thoughts?
I would say thank you so much for joining this conference. You guys have so much support at the IMF. If you don't know who your local expert is or who you should consult with, you can ask them all the time. In the Bay Area, whenever I see a new patient, I tell them, are you part of a support group? They say no, I send Jack an email, and then they are part of a support group.
There you go.
That's great. And so really you have a lot of support. So stay safe and good luck.
Thank you so much, Tom. And Dr. Mikhael?
I would just leave with an optimistic note. This is a depressing time on the whole planet. Every country is affected by this. We're all feeling down. And yet at the same time, I don't think we've ever seen this many drugs approved, not just in myeloma, but in all of cancer by the FDA over the last 6 months. But we are an exciting time of the disease, and we'll get through this together, as was beautifully in the sky in your slide, Brian. I thought that was magnificent. And I don't just try to look to the world with rose-colored glasses, but we are going to get through this, and we have so much more to do in myeloma, and we'll only be able to do it together. Even though I haven't physically hugged my friends like Tom and Jack and others, this has in many ways brought us closer together than I've ever felt.
Yay, there we go. Wonderful. And so, Susie, final thoughts?
My final thought is that I want people to know that it's okay to have a down day or to feel sad. But I've always said to people that are really in, like, oh, I'm miserable. I said, okay, lie down, cry, 5 minutes, get out and go do something, make something change.
Yeah.
Because you can't just be all pent up and not have any of that release, but you can't wallow in it. So it's okay to boo-hoo, but not for very long, and get out into fresh air.
All right. It's very strict. And so perhaps...
a glass of wine. Get out and fresh air with a glass of wine.
There you go. Now we're getting to the crux of the matter. Yeah. So Robin, some final thoughts from you?
Oh, I am just so very, very thankful to not only all of the speakers on the call and the IMF, but every single person that participated today, because I hope this call makes you feel better about the world, even though, as Dr. Joe said, it's the craziest of times, but we have each other. And even in a virtual world, we're all here to support each other. And if you didn't get your questions answered today, don't forget, you've got the IMF info line, and Paul and Judy and Missy are there to answer you. So that phone number, if you want to write it down, it's 1-800-452-2873. And they also have an email if you want to send your questions or concerns in. That's infoline, INFOLINE, all one word, @myeloma.org. And just a side note, if you are looking for a second opinion or doctors that are doing telemedicine appointments, they can help you with that as well. So again, thanks to everyone. And Dr. Durie, back to you as always. Thank you for being there for all of us all over the world. One Myeloma nation.
There you go.
And I want to end by thanking Mikhael and Amira for putting this all together.
Technical support.
Technical support.
Yes, which we very much need. So thank you for that, and also helping with the slide preparation. And so thanks again to our sponsors who make all of this possible. And so just a final thank you to our panel today. So thank you, Jack. Thank you, Tom Immune Martin. And thank you, and Joe Mikhael. So really appreciate your wisdom, your wise counsel about so many different things. It just makes such a difference, as Jack emphasized. When people are working in myeloma, it's a specialized field, and so having that wise input and, as Jack said, reach out to get it, because there are so many possibilities these days to get good counsel and to have the best advice. So thanks to you all, and we'll see you another time. And thanks to our patients who have joined us today. We sincerely hope that this has been helpful and given you true support in working through myeloma in these very difficult times. So thanks to everyone.